Matt, do you want to share the next talk, please?
Good afternoon. I'm Michael Fehlings from the University of Toronto, and it's a pleasure to take part in this NeuroTrauma 2024 Spine Day update. I'll be talking to you about some of the advances and challenges in degenerative cervical myelopathy. And I thought I would do this through the lens of the minimally symptomatic patient and also bring to light some advances that are emerging related to neuroprotective therapies and other diagnostic and therapeutic interventions. I have no relevant disclosures, but I have been the PI on a number of the studies that I will reference, and I would like to thank the organizers of today's meeting who are shown on this slide. So I'll be overviewing the pathophysiology of degenerative cervical myelopathy and some of the management options. And I'll focus on the challenge of managing the minimally symptomatic or mild patient, and I will discuss with you the emerging evidence that the sodium glutamate antagonist riluzole is an intriguing emerging option for degenerative cervical myelopathy. We coined the term DCM, or degenerative cervical myelopathy, in 2015, and this has now been widely adopted through the RICO DCM network. This encompasses a variety of benign, non-neoplastic, non-traumatic pathologies that compress the cervical cord. These include cervical spondylotic myelopathy, OPLL, and other conditions. Pathophysiology essentially involves three critical factors. There are static factors resulting in compression, and this alters the blood supply and results in ischemia of the cord. There are dynamic factors related to movement, dynamic compression, axial tension, as well as potential deformity or malalignment of the spine. And finally, there are biomolecular factors that result in an intrinsic spinal cord injury, and some of the critical factors involve inflammation, ischemia, and excitotoxicity. Over the years, the Modified Japanese Orthopedic Association a scale has been validated and adopted and has become the principal tool that's used to classify patients into mild, moderate, and severe impairment, as shown in this slide. In 2017, we issued the first management guidelines for degenerative cervical myelopathy, and these were published in the Global Spine Journal. This is one of the meta-analyses and forest plots illustrating the beneficial effects of surgical treatment at 6 to 12 months, at intermediate-term follow-up to 3 years, and at longer-term follow-up. And these diamonds represent the means of 95% confidence intervals, and these are well to the right of the 0-point line, indicating very large improvements that are seen with surgery. So based on this evidence, we were able to recommend that for patients with moderate and severe myelopathy, there was a very clear recommendation for surgical intervention. But there was greater equipoise seen in patients with mild myelopathy, where it was felt that one could either offer surgical intervention or a non-operative program, including structured rehabilitation and careful follow-up, and that this would involve a shared decision-making algorithm. So this represents a key knowledge gap and an opportunity for innovation. So how do we personalize the management of mild degenerative cervical myelopathy? And we clearly need to have better tools for clinical prediction, a better understanding of the natural history, improved outcome measures. I think microstructural MRI is emerging as an imaging biomarker, and I'll discuss this briefly. And then finally, how do we also incorporate genetic and other serologic biomarkers to aid in decision-making? So let me present this case scenario. So this is a middle-aged woman who presents with neck pain, bilateral particular arm pain, mild hand weakness. I judged her to have early myelopathy, and she has evidence of multi-level cervical spondylosis with cord compression, and she did have evidence of a pyramidal tract dysfunction, hyperreflexia, a broad-based gait, and hand intrinsic weakness. And these are the axial images here at 4556. C6 and C6-7. So let's play with this a bit and consider 3 clinical scenarios. So one would be, say, a patient comes in with neck pain, cervical stenosis, but no neurology whatsoever. And then the patient who comes in, they have neck pain, but they have a cervical radiculopathy picture. And then finally, the scenario that I've painted where you've got minimal neck pain, but evidence of an early myelopathy. And so, this is another patient here. How do we navigate, this type of situation where there's evidence of cord compression? There might even be myelomalacic changes seen on the T2 weighted images. And, what if the patient has no myelopathy or radiculopathy or minimal myelopathy? So microstructural MRI may become a tool that can be helpful, and we can assess atrophy and compression by looking at T2 weighted, T2 star weighted imaging. Magnetization transfer can be used to assess demyelination. We can assess axonal injury with diffusion tensor imaging and quantifying fractional anisotropy. And in particular, a measure that I think you could take home in applying your own clinical practices would be to use T2 star weighted white matter to gray matter ratio imaging. One can freely use the spinal cord toolbox that Julien Coedadat from Montreal has developed. This is available online and is a framework for template-based analysis of the microstructural MR images that can emerge. This is the paper published in the American Journal of Neuroradiology by Alan Martin, who at that time was doing his PhD with me, and Alan is now on faculty at UC Davis. And essentially, in this prospective study, including patients with DCM as well as with healthy subjects, we found that T2 star weighted white matter to gray matter imaging was an extremely helpful metric that allows one quantitatively discern the changes in the cord. And this is reflective of demyelination, gliosis, and other changes, and can help you predict which patients with mild myelopathy will need to undergo surgical intervention. And in addition, more quantitative, systematic ways to assess conventional MR images can be quite helpful as well. So diffuse T2 changes and segmental T2 changes, in addition to reduced T1 signal, are bad actors. They suggest a poor baseline status, and these would potentially also trigger a decision-making favoring surgical intervention. So we have a number of surgical options as summarized in this focus issue, but one of the important take-home messages from this article by Ree et al. Showed that about a quarter of patients with cord compression will decline over about a 4 to 5 year period. So these patients, if managed non-operatively, will require careful intervention in terms of an active, structured rehabilitation program and an active follow-up program. This is an important paper by Paul Matz, Daniel Resnick, and others. And this addresses the question of patients who have cervical stenosis and no overt myelopathy, but they have evidence clinically or neurophysiologically of a cervical radiculopathy. And these patients are at risk for further progression. And in fact, these are the types of patients that I will counsel toward surgery. So again, to revisit the AO Spine CSRS guidelines, moderate and severe myelopathy, clear recommendation for surgery, mild myelopathy, weaker level of evidence, and greater equipoise. So try to partially address this knowledge gap. We prospectively evaluated a cohort of patients with mild degenerative cervical myelopathy to assess the impact of this condition on health-related quality of life, as well as the impact of surgical intervention, and then to try to discern a personalized approach for management. We had over 700 patients in total in the series, and 193 of these patients had mild degenerative cervical myelopathy. what we found was that although the clinician would rate these patients as having mild cervical myelopathy, patients themselves often reported marked changes in the SF-36, including mental health and physical component summaries of statistics. And so patients with mild DCM can have quite significant impairment in quality of life. So it's important to ask the patients what the impact of DCM is on their health condition. And in these patients, surgery improves function, disability, and quality of life. But there is heterogeneity, and we see that over half of patients do have a major improvement in their neck disability index and have improvements in their health-related quality of life, but not everyone does. So if we use machine learning, and here's a cluster-based machine learning algorithm with a principal component analysis, we see that there are some negative predictors for a poor outcome in patients with mild myelopathy. In older age, significant medical comorbidities, and smoking, perhaps as a surrogate of other health-related issues, are negative predictors for outcome. And interestingly, in these patients with mild cervical myelopathy, it does appear that there is a differential effect. There is an anterior versus posterior surgery, and it looks like anterior surgery is associated with improved outcomes. So very interesting. So an approach that you could take in the clinic is if you see a patient with mild DCM, you can assess their health-related quality of life, either using SF-36, EQ-5D, or asking the patient. And if there is a significant impact, do they have pain? And here, for example, you use the neck disability index. And if you see that there's an impact on health-related quality of life and significant pain, these patients will respond well to surgery. And if not, you might want to pursue a non-operative protocol in these patients. So how did I manage this patient? Had mild myelopathy, multi-level cervical spondylosis, and I liked the multi-level ACDF. This is quite a straightforward procedure. The patient had an excellent outcome, overnight stay in hospital, is entirely free of radicular myelopathic symptoms and signs, and a long-term follow-up. If you do choose to follow the patients with mild DCM, be aware that it may not always have a benign prognosis. And in this prospective cohort done out of our center, over 50% of patients with mild myelopathy did end up deteriorating over a 2 to 3 year period of time and required a surgical intervention. I think that the application of genetics is going to have a big future in terms of personalizing the management. And one gene that has emerged is the ApoE4 gene. This is part of a family of molecules that are on the cell surface of neurons and glial cells. And these modulate the response to stress signaling, including inflammation. Most patients express an ApoE3 subtype, and about 10% of the population is ApoE4 positive. If you are ApoE4 positive, your risk of the development of Alzheimer's disease is substantially higher. And it turns out that if you are ApoE4 positive, your response to surgery is not as good. And so this may be a very interesting genetic biomarker to be examining in future studies. So some perspectives on mild degenerative cervical myelopathy. Overall surgery is safe and effective if you choose the right patient population, but mild DCM is heterogeneous. Pain, unsteady gait, weakness are associated with greater baseline impairment, and also associated with greater gains following surgical intervention. I tend to favor the anterior approach for patients with mild degenerative cervical myelopathy. And I think the assessment of health-related quality of life through the SF-36 and potentially the NDI is a useful way to go in the clinic. So in patients with neck pain, cervical stenosis, and no myelopathy, I would advocate for careful observation and a structured rehabilitation program. If there's neck pain and evidence of radiculopathy, I will generally recommend surgical intervention. In neck pain and early myelopathy, I would recommend surgery if the symptoms are having an impact on quality of life. Future clinical decision analysis will benefit from other approaches, including machine learning and artificial intelligence, microstructural MRI, and genetics, including assessment of ApoE3 versus ApoE4 status. So what else is emerging? And I'll try to briefly present and ongoing translation, as well as perioperative ischemia, reperfusion, injury that can provoke neuronal loss, oligonucleal cell loss, and is also associated with damage to the blood spinal cord barrier. So riluzole is a sodium glutamate antagonist. It's an FDA-approved medication, and the on-label use is to slow down or attenuate nerve cell degeneration in ALS. And essentially, our clinical trial, which I'll briefly present, represents a repurposing of this drug. This is the report in the Lancet Neurology, and I'll also present an updated a report that was recently published in JAMA Network Open. So in this prospective randomized clinical trial, we sought to address some of the issues that we see, that there are patients who can have perioperative neurologic complications, including C5 radiculopathy, and we see a variance in terms of the improvement in MGOA. Some patients have large improvements, some patients less gain, and a small proportion of patients who decline. And riluzole in preclinical studies has been shown to block perioperative ischemia reperfusion injury and attenuate neuropathic pain and enhance functional neurological recovery. So based on this, we launched the CSM Protect clinical trial. This is a registered trial, 16 sites across North America, 300 patients were enrolled. And patients received riluzole or placebo in a blinded fashion 2 weeks prior to surgery, that underwent surgery, and then received the drug for 4 weeks after surgery. The primary endpoint that we examined was a change in the MGOA, and that may have been an error because we ran into ceiling effects and lack of sensitivity of the MGOA, and we looked at a number of secondary outcomes, including health-related quality of life outcomes, as well as pain scores. So this is the summary. 290 patients ultimately were enrolled. Just under half were female, high rate of follow-up. The patients were well balanced in terms of the riluzole and the placebo groups, and complications were low and were balanced between the two groups. So this is the primary analysis, and we see the baseline MGOA scores of around 12 and a marked improvement with surgery, but we did not see an added beneficial effect on MGOA recovery with riluzole, and may represent a ceiling effect in hindsight as a result of the fact that the patients improved substantially with surgical intervention. On secondary analyses, however, we saw important improvements in both neck and arm pain with riluzole intervention, and this was also reflected by improved SF-36 physical dimension scores, as well as improvements in hand intrinsic function, as judged here by the changes in the Asia motor scores. So we missed the primary outcome measure on the MGOA. We had significant benefits on 3 predetermined secondary outcomes: VAS neck pain, Asia motor score, and SF-36. So we've now undertaken a reanalysis using an alternative technique called the global endpoint. And this is where, instead of just using one endpoint, use a multidimensional technique, and you combine different endpoint readings to get a multidimensional assessment of the patient. And here we looked at quality of life using SF-36, pain scores using the neck and arm NRS scores, neurologic function using the Asia motor score, and functional status and disability using an alternative to the MGOA, namely the neuric rate. And when we do this and we combine these outcomes in terms of global statistical test, sure enough, we see statistical significance favoring riluzole, and we see beneficial effects as early as 35 days after surgical intervention, at 6 months, and most strikingly at 1 year. And the probability that a patient would improve with riluzole is over 50%. And so from an intention to treat analysis, if you see 10 patients, 5 of those patients will likely have a beneficial effect with riluzole. So take-home messages. Degenerative cervical myelopathy is the commonest cause of spinal cord impairment in the world. Surgery for DCM is safe, improves neurologic function, quality of life, and is cost-effective. Riluzole is emerging as an effective treatment, which is an adjunct to surgery. And future directions will involve an increased awareness of DCM, and this is a shout out for the AO Spine Recode Project, the optimal management for patients with mild DCM, the use of imaging, serological, and genetic biomarkers, and the application of neuroprotective and neuroregenerative strategies. And on that note, I'd like to close and thank you again to the organizers for the privilege of presenting at this outstanding meeting.
Thank you so much, Michael. It was really informative as usual, and great presentations, and